Thank you so much. Thank you. Well, good morning, everybody, and thank you guys for joining this session this morning. I'm Don Armstrong. This is my colleague and good friend Keith Hall here.
Morning.
We're both pleased to show up, and we got together a couple months ago. Actually, about the last 6 months, we've been talking about this topic about how do we build a path from our biomed into an imaging technician. Kind of a topic where I'm the technical trainer. I'll just go right to my slide here. Well, let's go to the purpose of our session first. You see, we got a blue and a red dot here. That's my funky way of saying Keith and I are both talking on this slide versus me or Keith. So you're going to see those little dots. That's what they mean. So yeah, we wanted to kind of an outline. This is something that's been coming up in our company, Renewable Solutions. We have a lot of technicians that are interested in imaging that come in as biomeds, right? So we're trying to kind of formalize a way to build that pathway, right? So how many in this room are imaging technicians versus biomeds? How many are imaging technicians? Both are imaging. Any biomeds in the room? Yeah, I'm a biomed. I'm not an imaging technician. So Keith, what are you?
I'm a little bit of both.
You're a little bit of both.
Yep. I'm
good. Well, I would like to say I'm a little bit of both, but I am pretty much more of the biomed world. So what we're going to try to cover today is how we transition some biomeds have a pathway from biomed to servicing engineers, the required mindset it takes to make that transition, and the training investments it would take for either the individual or the company that they're working for, hospital they're working for, whatever it might be. Whether you're going to have some kind of structured development, whether it's just going to be strictly OJT or mentoring along to make that work. And then a little bit of the overview of the CRES certification. Keith and I both worked really hard last year to get our certifications last year for CRES. Keith, why don't you take a little bit of that?
I want to jump in and ask, we kind of skipped one group of folks. Anybody in here identify as a manager? Or yeah. So kind of the so what of this class, why do we care? There's a gap, and we're going to get into all these details. This is kind of my intro statement here. There's a gap between the need market for skilled imaging service, labor, experience, right? And the available staff.
Mm-hmm.
And we're in a company where you can either build it or you can buy it. So you can go out to, if you're in an ISO or a hospital and you need a skilled imaging engineer, you can go and recruit a skilled imaging engineer. But oftentimes the pickings are pretty slim and you need to build one from your existing biomed staff. And that's kind of why we put this presentation together. We're going to talk about understanding the imaging pathway, because it's slightly different than it is for biomed. The difference in skill sets between biomeds and an imaging engineer. We're going to talk about how the organization can support it, putting together an actual plan that has a thoughtful front end and a follow through on the back end, and what resources are available and needed to support that imaging engineer's growth and sustainability so that they remain technically relevant. Thank you, Don.
So a little bit about us. So I'm Don Armstrong. You can see I got a bunch of these little funky little things behind my name. I don't know if it's going to work. There you go. All these little letters here. I worked real hard for the last many years to get all the biomed certifications I can. I'm kind of a firm believer in certification. Now, you can be a great biomed without having CBET behind your name or CHTM or whatever. You could still be a great manager, of course. But I'm a really firm believer in continuing to grow, continuing to learn. I'm a 64-year-old guy. I've been doing this for 40 plus years. I think I'm at 43 years now in the field. So it keeps me fresh, keeps me kind of moving forward, right? Currently, I'm the technical training manager program or program manager, or however we want to say that, technical training program manager with Renewable Solutions. I've been with them since 2020. CBET since 2006, CHTM since 2016. In 2023, I decided to take the CAPT exam. I don't know if most of you aren't biomeds, but the CAPT is a certified associate biomed technician. It's kind of an entry-level certification for biomeds. I reached out to my leadership and to Amy to say, can I take this? I mean, I've already been CBET and CHTM for years. And they said, no, if you want to go ahead and sign up and take it, go ahead and take it. So it's a really good entry point to the field of biomed for sure. Been CRES since 2025, last year. held lots of positions in the biomed world, coming in as a biomed, then becoming a senior biomed. Then what we called a certified biomed when I worked at Stanford. That was just a position that they held for us. Did some work with the quality team with GE Healthcare. Senior manager, ultimately one of the bigger hospitals I worked at, and now the technical training manager. And you can see I've got this little caveat here, the becoming certified was one of the biggest milestones of my career. If you're in the imaging world, I really suggest you to do the CRES. It's a great exam, it's a tough exam. One of the harder exams that Amy puts out there. The passing rate is just a little bit over, I think it's just a little under 60% of people that take it pass it. But you know, a little bit of work and dedication, you can certainly get there. And there's Mr. Hall.
Yeah, thanks, Don. Being in the HTM space has been my one and only grown-up job after I was a teenager. I went into the Army in the 90s to be a biomed, right? Cool. So back then it was a different type of world. It was pre 9/11. I went into my first shop and I was working on sterilizers and dental equipment and pretty much anything that they could throw at me. Through that, I ended up in a program mid-career. I had a decision to make if I wanted to stay more technically relevant or if I wanted to become more of a Army leader where you peel away from doing the HTM work and you end up just leading soldiers more. I thought it might behoove me for the future to try and stay technically relevant. So I applied for and was selected to attend a training with industry program. For those of you that are familiar with the military and even those that are not, it's where I did a permanent change of station for 1 year from Fort Hood, where I was stationed, to Cleveland, Ohio, where there's no Army installations. I went to the Phillips training campus and they dropped me into the third week of a 4-week-long CT school. And they said, this is what you're going to be teaching, so soak it up. And we were talking about data path diagnostics and I barely knew how to spell CT. So it was a sharp learning curve. I learned CT and then I turned around for the next year and I taught the CT repair course as a Phillips instructor wearing a Phillips polo, but getting a paycheck from the Army. And about 6 months into training on CT, I finally understood. I had one of those epiphany moments where a student asked me a question and I didn't instantly have to go get one of the senior instructors to explain it because all the pieces of everything that we had been teaching and learning instantly came to me. And then it was like, after that moment, you could ask me anything about the Phillips Brilliant CT, and I knew how it all worked inherently. It was amazing. So when I had left there, I went to a follow-on assignment out in California, where the Army has its Center of Excellence for Radiology, and I quasi-managed the global CT service program all around the world. We talked about things like don't oil the slip rings in the desert because it just sucks up the sand and sticks to it and it burns up the brushes real quick and things like that. Then I did some other leadership roles for the last 3 to 5 years of my time in the Army. When I got out in 2020, one of the contractors that worked with me at Hill Air Force Base that you saw said, have you heard of this company called Renovo? So I joined Renovo in 2020, right at the height of COVID. It was April 2020 when I got out and I went to go work at the University of Utah as an account director. It was a 2-man shop. We supported a bunch of stuff there. And over time, over those 2 years, I helped kind of fix that account and grew. And a position came open to move to a new role, being a director of service for imaging. That's where I currently work, and I love working there. I help support imaging service plans throughout the Western United States. So every imaging device that we have under our control, I make sure that we have a primary, secondary, oftentimes tertiary plan to do preventive maintenance and repairs on demand maintenance. Thank you, Don.
Well, Keith is underselling himself just a little bit, everybody. Keith has kind of become a really big leader in the imaging space. You'll see him at most of the conferences, leadership forums. Keith is becoming a really strong voice. He manages all the imaging on the West Coast. I think he said that already, but you know, he's a guy that I look up to because he knows the industry world well. He's a fantastic leader of his staff. So I'm really thrilled. We joined Renovo right about the exact same time, 2020. I joined in June of 2020. So we are both very lucky to be part of this. So here's what the transition pathway. This is why we're here. I do a lot of training of newer staff, our newer biomeds in Renovo. And one of the first questions they come to me with after we're saying, What do you want to do with your career to start building your career pathway? What's on the horizon for you? A lot of them say, I'm really interested in imaging. And I've been a biomed my whole career. I've never really been interested in imaging. I know it's there. It's just been not something I was really taken with. I'm an OR guy, worked on ventilators, worked on in the OR equipment for a lot of years. So imaging was there, but I just really never really saw a pathway for myself. I think a lot of biomed technicians see there's more money in it. It's a different lifestyle, right? They're traveling from hospital to hospital. They see it as a little bit more of a romantic type of situation for them. So I think his mic does not be a little low. I think you guys can hear me okay, right? Maybe too much. I hear you. So the first thing we wanted to do when we started actually fielding these questions were, okay, so let's identify if you have some kind of skill set for it. We know that maybe you want more money, you want a different like lifestyle, you don't want to go in and just do routine biomed PMs and stuff every day. So let's identify to see if you have the skill and the acumen for this, right? And to understand what it takes, right? So we will have them, pull them aside, have a conversation with them, maybe bring in a Keith Hall, maybe bring in a Shelby McCarthy from some of our imaging specialists to say, hey, listen, we got someone that's interested. Maybe you have a conversation with them. Because believe me, once I have a manager that has a really high performing biomed and they want to go to imaging, it's kind of becomes a little bit of a tug of war, right? If it's within the same facility, hospital, or organization like Renovo, because we have 600 employees out there between biomeds and the imaging technicians and managers and stuff. So if we get a great imaging tech, that might mean we're going to lose a great biomed from a site. So we have to really work on that from a professional standpoint and a personal standpoint, right? We hopefully those goals align. If it aligns professionally, that's great with their personal life. A lot of technicians don't know what it takes to be a really good imaging tech, including me. I don't really know either. So the first thing we want to try to do, if that we can actually foster that interest, is to mentor them up with somebody or match them up or partner them up with somebody either on site or in the field. We have Roger, one of our really good field engineers, specialists out here. He might notice somebody, or we might say, hey, listen, next time Roger's in your site, maybe just shadow him for a while, right? See if it's actually something you want to do. Once we can kind of pinpoint that, then we can maybe assess a little bit. Sorry about that. Maybe then we can assess the progress and design some next steps for them. We just don't want to say, no, that's not for you, right? Because the entry point for biomed and for our imaging specialists now have changed. Right? It used to be you had to come from industry, you had to come from the military, you had to come from some formal training to get even your first step in there, get even a little toe into that world. You had to come from something already. Do you have a question?
I've got a whole slide for it. I've got a whole slide on it coming up.
Yeah, that's a good question. And me coming from the biomed world and manager of biomeds, I mean, sometimes you see someone that you really think has the desire, but then you're thinking, like, from my standpoint, what skill set should I really be even assessing? I don't really know. You know, are you willing to, you know, are you willing to be on call all the time if the CT goes down? You're working 6 to 2:30 now. Are you willing to really change your whole lifestyle to be an imaging person? I mean, at least that's the first thing I think of, right? And most of them say, yeah, because it's more money and it's more opportunity, maybe, you know. It's like I said, but that's why I interact them with Roger or with Keith or Shelby to say, you think it's this, but here's what it really is, you know. This pathway matters for the future of our field and just the engagement of employees, period. Because again, you don't want to take someone that says, I really want to image it and say that's not for you, you're a biomed, you know, kind of, that's it. Or you have to go out and get an entry-level job somewhere else, right? So we want to make sure that we're addressing some of the aging workforce in HTM, the needs for the imaging techs, just like there's a need for biomeds. And in our keynote yesterday, I was really surprised to hear there's such a need for radiologists. I didn't know there was such a deficit in that too. I mean, I guess it's everywhere, right? I'm pretty myopic when it comes to my biomed, I guess, feelings, right? And we want to make sure we have some development so HTM folks feel like they can go into imaging. Jaime, you've been a biomed for a long time. Have you ever wanted to go into imaging?
I like it at times. I'm the biomed more technical, right? So like, you know, pressure, voltage, stuff like that. Now with imaging going to digital.
Yeah.
That makes it a lot like can't connect my to actually one.
Right.
So that's where I have a
I hear you. And you're CBET too. Have you ever done much imaging? What's that? Oh, general rad right now? Awesome. That's really awesome. Is there biomeds in the room that have transitioned to imaging, or are there biomeds that are doing imaging work too? Really? Where do you work, if you don't mind me asking? Yeah. Oh, okay. Oh, gotcha. That's awesome. Yeah. Well, I've been, like I said, a biomed 40 years, and I took the CRES because I was in a leadership role, managed our imaging team for a while. So we'll get more into what the CRES requirements to take the CRES exam. But again, we just want to make sure that there is that career path within our organization, and for biomed to realize there's more than just the straight path. It could go wherever you kind of want it to go. Okay, so what is CRES, right? So CRES, we talked about in the title, went from HTM to CRES. It could have been HTM to imaging, but we went ahead and throw in the CRES right on top of that as well. You know, the CRES is a certified radiology equipment specialist offered by AMI. The test is twice a year, 165 questions. You roughly got to get about 72% of that test correct. Those answers correct. Gives you it's a really good test. Keith, like I said, Keith and I worked our butts off last year to pass it. It's no joke. Has any of you taken the CRES? How'd you do? You keep it up. I care. But you didn't keep it up. You gonna take it again?
Maybe we need more classes like this to keep raising awareness.
Yeah, and it you know, and it's really interesting too. A lot of, because I work with a lot of biomeds across. Again, I told you just a minute ago with Renovo, we have over 450 biomeds. We probably have maybe 10% of our workforce is certified. A lot of them are coming from in-house programs or other organizations that didn't either emphasize it or have incentives for it. Our company, we really worked hard the last couple of years to build in incentives for people to take it, because a lot of them is what's in it for me. I'm going to go out there and stick my neck out and maybe not pass, and for what, right? So luckily enough for our company, we incentivize it. We have a pretty good policy for, you know, a bonus if you pass. Like I say, something like $1 an hour more and a free day off, right? We offer that, and possible going to these kind of conferences. That's a big deal for a technician to say, oh, so the company does care. And plus it travels with you, right? If you're a CRES, you can come to me and you say, hey, listen, I want an imaging position at your hospital, and I see CRES behind your name. It's a pretty good thing to do, right? In 2025, the CRES test changed a little bit. Again, they did a job task analysis in 2024, Amy did, to ask imaging technicians and biomed technicians, what are you guys actually doing? I mean, are you doing 10% of your time doing hardcore electronics? The answer was no, we're not. We're doing electronics, we should know about electronics, but we're not doing 15% of our time troubleshooting transistors, right? So they knocked down the percentage of questions per test. 165 questions, 25 of it now is HIT, 25% of it is equipment, knowledge of equipment, 25% of it is troubleshooting, right? That's 75%. So now there's 10% of it is anatomy and physiology, 8% of it is safety, and 7% of it is electronics. I think that's right. That adds up to 25, right? 100. 3-hour test, 165 questions. I highly recommend you go try to look into it. Take the CRES. They have a CRES study group now. There's all kinds of information out there online to go ahead and really think about taking that. It's a really good test. Keith, I'll let you do the rest of the second part.
We're good. We can go to the next slide.
Huh?
We can go to the next slide.
Oh, you want to go to the next slide?
Yes,
Okay.
please.
So yeah, like I said, we just, you know, we went over what exactly it is. Oh, you want the slide and the slide after that and the slide after that.
Okay, so.
Okay, let me come back. There you go.
Right, so we've talked a little bit about the need for this transition, tapping into our biomed staff to grow the talent rather than go out and buy the talent. This transition is going to be most successful when a structured development plan is in place, utilizing these 3 arms. Okay, first, you're going to have to make sure that there are training programs planned for. You have to have a mentorship approach. And then the person that's making the transition needs to actually turn the wrench. They got to put their hands on the equipment to build that muscle memory. Okay. So for training programs, we're talking about an internal training program. Some organizations are fortunate enough to already have skilled imaging service engineers in their ranks and their staff pool. So you can consider that. It pairs nicely with OJT, on the job training. That's one option, is kind of the train them yourselves methodology, and that's okay. It might not be the top tier. I think probably the top tier of training would be going to the OEM school. If you're going to be working on like I'll use my example, the Philips CT scanner, the best training you can get is going to Philips and getting the training. I saw a few heads shaking there. There are also outstanding options to get training from independent service organizations. Can somebody in the crowd just raise your hand or shout out one of those training organizations that you can think of off the top of your head? Yes, sir, in the back. CBET, CBET, that's right, College of Biomedical Equipment Technology. That's a great one. Anybody else got another one for a device-specific training? RSTI, that's another. We're going to have a slide at the end of this. It's going to list like, I don't know, 6 or 7 of these different ones. Quick Google search can find these types of trainings. So you got to have training so that the person making the transition can start to understand the clinical applications of radiology imaging, how it's different from all of the different types of things that a biomed might work on. Biomeds work on things that include therapy, diagnosis, treatment, monitoring. Radiology and imaging is quite different. It's just looking inside your body without having to get out the scalpel, right? At the end of the day. So mentorship approaches is the next arm. You're going to want to choose, Don talked about this a little earlier, choosing the right candidate to make the transition is important. And we'll talk about some of the skills and attributes that that candidate should possess on a future slide. We're going to talk about what makes somebody a good prospect to transition into imaging. Things that they have inherently that you can't teach, and then maybe they're adaptable and you can teach some of the things. But just as important as choosing the right person to transition is choosing the right mentor. Okay, you might have a mentor that can hang x-ray tubes all day long and they're really great at it, but their communication skills with the customer are subpar, right? They're typically calling somebody in radiology names behind their back, or they have a poor, whatever, fill in the blank for personality flaws. Maybe that's not the person that you want to select to be the all-around mentor for this person that's making the transition. Okay, you don't want to necessarily ingrain some of these traits that you'd rather not see by selecting the incorrect mentor. And sometimes people don't think much about that. They think, oh, old Bob over here is really great at x-ray, and let's have him be a mentor. And then next thing you know, you have another mini Bob running around with all the same things that drive you crazy about Bob in the first place. Having set expectations and follow through. So much like this is a lot to the managers, people that identify as managers in the room. Just like any other project that you're going to take on in your HTM organization, you got to have a plan. Having a plan is great. You're going to say, we're going to do all of these things. At the end of the plan, you need to be able to follow through and measure that. Was it effective? If not, how do we readjust and reapply and measure it? Standard stuff for managers. Follow through can be things like having somebody who's not the mentor check in with the mentor and say, hey, how is Mini Bob in this example? How's Mini Bob doing? Is he coming along? Is he listening to you? Is he receptive to what you're teaching? Follow through could be following up with Mini Bob and saying, hey, Mini Bob, show me some demonstrated skills that you've learned in your time as a mentee. And the last piece, like we said, hands-on experience, turning the wrench, doing the PMs. That could be following Big Bob around and watching. So for those military folks in the room, we used to have a saying, probably still do, watch one, do one, teach one. So you observe the skill being performed, then the next time it happens, you are the one performing it with the supervision of the mentor, who's maybe just standing by ready to answer questions or divert a disaster. And then after some demonstrated excellence, you become the mentor and you start teaching the next generation. This is how doctors become doctors, surgeons. The only one who can train a surgeon is a surgeon, right? Only people that can train imaging engineers are imaging engineers. Volunteering to tag along to learn. So these are all great ways for a structured development program to ensure that you have success in that transition. Next slide.
I know we just left off this slide. I'm going to go back just real briefly because I like to always ask people, is there anything else you guys could think of we could put on this slide? Is there any kind of other training programs, mentoring approaches that we're missing? I mean, I know we didn't capture everything, but anything you know that works? Because I know it's hard, it's complicated. If I'm managing a site of 10 or 12 biomeds and I have a couple imaging technicians in my team, I get someone I know will be good at this. I just have a feeling they'd be good at it, but they're so busy during their biomed work, and the imaging techs are so busy to grab another person and have them tag along. It's hard for me to actually make that happen. You got any suggestions?
I guess one thing that I would throw in there, maybe it falls under JT or maybe not, but how is the equipment used is something that I think really benefits somebody.
How the equipment is used?
Yeah,
Oh.
you go watch Carnegie Academy to see how the placebos is used to image the heart. You have to sit for a day in the X-ray, watch them do review needs. But just to kind of understand how the equipment is used, so not just working with biomeds instructors, but go out where the devices are being used, whether it's the OR or similar radiology or nuclear medicine, and see these things being used. I think this is something that really adds a lot to the takeaways.
I'll tell you, I'll follow through on that. This is an interesting one. I was covering a smaller site in Texas right before I was going to take the CRES exam. And it was it was in a small town in Texas, not your site, but another one trying to think of the town it was now. I can't remember. It was a small town in Southeast Texas, small two-person shop. The one person had to go on vacation, so they brought me in from my training program manager job to come in and cover for a couple of weeks, and realized it was a pretty mellow site. And I found a way, had the head of facilities introduce me to the director of imaging. So I went to him and I said, listen, you know, maybe it's because I'm an older guy, a little more experienced. I have the gray hair, so I think maybe he realized I wasn't just farting around, if you will. So I'm getting ready to take this exam. I said, I really haven't got much experience with mammo or with the PET scanner or some of these other modalities. I just really don't get a chance to see that much anymore. Is there any way during this next 2 weeks that I'm here that I can just check in with you every morning, see if you can let me just shadow along? And really just with even that approach, he was like thrilled to like pass me up with the mammo director. She had one machine and she showed me what it was. I mean, I hadn't seen one for a while. So when I heard face guard, I really didn't know what a face guard was until she put me in front of one. I said, oh, it's just some plexiglass thing they put their face against there. I didn't know that. So yeah, having the courage and having the right way to ask that is really important, right?
I guess the other thing to be is what's the impact on the machine? So if you're talking to that end user or their leader, okay, so your whatever is broken, what's the impact on patient care? What's the impact on finances? Why is your job as imaging tech really vital? Why is your job important? How do you contribute to patient care? And what's the bottom line of financial impact? How's this going to make a difference?
Right. Do you guys kind of all agree with what he's saying? I think so too.
How fast it will hit and that type of exam because their schedules, because of all the regulations, like those type of things that you can't really get or understand if you're not in the trenches.
Yeah. Yeah, even like when I was working with the mammo director, I'm like, well, this thing goes down for a day or two, what impact does it have? She goes, I'm having to cancel patients or divert them to another facility. She goes, and this could be weeks for them to get rescanned. And because I'm not moving Friday's cases off Friday just because Wednesday doesn't work. You know, so yeah. Yeah. Yeah, believe me, this is to me, I know we got a lot more slides to go, but we have some time. You know, if an infusion pump goes down, there's 2,500 more infusion pumps behind it, right? If a mammal system or a CT in the back end of the OR goes down, that's a whole different ball of wax, right? John, yeah, please. Sure, sure. Yeah, absolutely. Maybe Keith or Shelby maybe could talk more about that, but I know when I was at Stanford, we had what's called a partnership contract where they did all the really heavy stuff and our biomeds did first call. It was a cheaper contract, but it was kind of like just some nominal training. Is that?
It's like a shared services agreement. Right?
Yeah. Well,
Yes,
I appreciate your input because like I said, we have, yeah, do it.
Look, I would say, well, clinical perspective is if you got a bullet in a lump in your breast and the mammal goes down, the anxiety going through is huge. And so if they're doing a week, that's a whole week.
Yeah,
of
yeah.
not knowing what's going on.
Yeah, absolutely right. So these are the kind of, like I said, these are the things that are a good mentor, a good, I don't want to say, someone like Keith or someone like Shelby could really sit down and talk with someone. But like, I love what you said, having the ability to interact with them and see how the equipment is used. And really, that's a good part of the CRES exam too. I mean, you got to know what the units you use for and what actually all that stuff stands for, means and all that kind of stuff. So believe me, that 2 weeks I had at that hospital just really, really saved my butt when it came to, because I really had PET scanners and, you know, I know about CTs and MRs and general X-ray, but the mammos and the specific stuff was a little more difficult for me. Okay, we'll go over this real quick. I think Keith, why don't you start on the top if you don't mind, if you're good for that.
Yeah, sure. This first one up here says you got to first decide that you're going to do it.
Yep.
All right. So once you know you're going to do it, then start taking the actions to support it. Schedule it. Get studied up on it. The day of the test, it says get there early. Of course, you want to get there early. Get a good night's sleep, and then you guys are all doing this right now. Upkeeping CEUs for easier for your recertification.
Keith and I get 2 for this today, so
Yes,
you guys get 1 for watching this. We get 2 telling you this. What's that? Oh
No,
yeah, well, I'll take 1.
We multiply them.
Yeah.
Right, 2 times 2.
This is more challenging than you speaking with him just by my, no, I'm only kidding. Your challenges are going to be, of course, the time to study. When do you study? Finding the correct material. Now it's getting better and better and better and better. I mean, my pal ChatGPT could actually print out a CRES exam right now for you, which I've kind of done for a lot of my colleagues because, you know, I know the guy that teaches the CRES review course and I'm not pilfer off his stuff. Just like I teach the CBAT review course for Amy, and I really can't give you guys the material that I teach unless you take the course because I signed an NDA or agreement. But I can put together practice questions for my staff, you know, because I don't know the questions on the exam. But, you know, I think one of the biggest things for this is this decision to take the test and scheduling it. Once you put that down on paper, then you got to kind of start working toward it, right? Really not all that hard, man. It's a question and there's 4 answers. The answer's right there. All you need to do is pick the right answer, right? I'm not trying to be too flippant about it because it is something. So finding the correct study material, and will I be compensated for this, right? So a lot of people say, what's the use? Why would I do it? With Renovo, we worked real hard to incentivize it. Maybe you're a hospital, maybe your company could do that as well, you know. Our company pays for the first shot at the exam. Used to be old school thinking used to be, we'll pay for you if you pass. We won't pay for you if you don't pass. Now we're going to pay for you if you take it, and if you have to retake it, that's on you. So it kind of throws a little bit more, I don't know, just emphasis on the study. You won't have to pay for it again if you pass it, right? I know a lot of technicians from the biomed world and the CRES and the CHTM was, I'm just going to go ahead and take it, see what happens. I'm against that because you won't pass if you're going to take that kind of approach. It's not that hard. Just do a little bit of studying. Once you pass the exam, then you want to make sure you keep up your CEUs. Passing the exam, like I said, it's a big milestone to get your CRES. There's only so I think there's only like 300 or 400 CRESs out there, so it's still pretty unique and pretty specific. Keith, I'm going to let you go from here.
Yeah, that's what we were talking about. Mike was asking a little question. We're going to talk about a lot on this slide and the next slide. A career pathway is a great tool to have. And I was fortunate enough to help develop a career pathway for the organization that I work with. Do we have any BMET 2s in the room? BMET 2? Okay. If you're a BMET, raise your hand. How about that? Biomed. What would you identify as level-wise? Manager level? You too? Okay. So not a lot of biomed 1s probably come to this conference.
Yeah.
Oftentimes they don't. So that's why I shot for BMET 2. But imagine you're a BMET 2, because I imagine that you probably were a BMET 2 at some point, both of you in the back that identify as managers. Have you ever sat there as a BMET 2 and wondered, what are my career options from here? Right? Where do I go? Do I specialize? How do I become a BMET 3? How do I get into imaging for that sweet extra couple of bucks an hour? Whatever it is that you want to do, having a pathway to progress is great. So we had a committee and we defined, what does that pathway look like? It's a tree where you can branch off and you can go into clinical engineering. You can go into imaging, laboratory equipment, specialization, right? You can promote up to BMET 3. You can go up through management, et cetera, et cetera. And if anybody wants some input from me after the class, I'd be happy to share some of that tree with you. As a BMET, we have core clinical engineering skills. Who can name a skill that's desirable for a BMET to have? Communication, that's great. So somebody that hosts the 5 o'clock news has great communication. Would they make a great BMET? Maybe, maybe not. All right, what's a BMET specific skill? Customer service, right? The lady helping you buy a pair of pants at the department store has great customer service. Would she be a great BMET? Maybe, maybe not. Are there any biomed specific skills?
Their skills of trying to
Troubleshooting.
a problem, how are you going to solve it? Sometimes not really clear, but if they have a goal, that means I'm like, come on, you know, we just got to start digging into it.
So what I'm hearing is, I'm hearing critical thinking and troubleshooting for electronics, pneumatics, mechanical, right? Great, those are pretty specific to making a good biomed. Preventive maintenance. What underlying skill would you look for to know if somebody does a good job at preventive maintenance? Speak up. Documentation, that's a great one, I love that. I was thinking first and foremost, attention to detail, right? So you've got a set of instructions and it says, I don't know, clean this in a counterclockwise direction. There's probably a good reason it says counterclockwise. You want somebody with good attention to detail that follows that. So I think we talked about troubleshooting, critical thinking, attention to detail. There's troubleshooting right there. And these are some of the foundations that you would identify are great in a biomed. You want those skills, okay? In an imaging service engineer, I would argue that these skills that make a biomed great are foundational. These are great skills that you can build on when you're building an ISE. Do you have to be a biomed before you become an ISE? No, not at all. A lot of people walk into the imaging service engineer career field with no knowledge of how to use a safety analyzer or what a defibrillator is or does. But more and more, we're building them, and that's what this class is about. So because that's the nature of this class, I would argue we take biomeds with great foundational skills and we seek to build upon those to make a great imaging service engineer. Some of those skills that an imaging engineer should have is knowledge about those imaging modalities. I've heard speak of mammo machines, right? They should know the clinical use for the clinical applications for a mammo machine. Not only what they use it for on the patient, but how does that machine work, right? What makes it tick? Higher complexity repairs. Is it more complex to change out an X-ray tube or to disassemble a defibrillator and reassemble it? One of those fancy Zolls? I would argue not really. Not really. The Zoll's probably more complex. I hate that little ZIF connector or whatever it is, always breaking. It's pretty complex. To say that advanced, higher complexity repairs, maybe. I would argue potentially higher complexity preventive maintenance, higher complexity calibrations. That would probably be fair. Increased downtime urgency, we nailed it, right? Some folks over here were talking about when that system's down, there's a higher sense of urgency. How many of you know what happens to a hospital when their ERCT goes down? Yeah, it creates a big problem. The hospital goes on divert or diversion status. What does that mean for the surrounding community, the place where you live and the people that live in your community? It means that somebody could be involved in a vehicle accident right outside of that hospital, but they can't get care there because they need a full body scan, CT, to see where the trauma is, where's the major bleeding, what's broken, is there metal inside their body? And so they have to get transported 45 minutes away to a different hospital, and oh no, they died en route because that CT was down. So when you're developing a BMET to imaging service engineer, it's crucial that they understand those implications of the increased urgency and downtime, which was some of the conversation that we were having a little bit ago. And I think that's great because I guarantee you that the hospital staff, the radiology director, the C-suite, the administrators of the hospital, they understand it, not only for the urgency and the outcomes for patients that are critically injured, but to the hit that they take on their top line, right? It impacts revenue. When that CT scanner is down, they're not making money on that CT. As a result of this, you need somebody with, who said it over here? Was it Mike? Good communication skills. That increased downtime urgency, communicating quickly, clearly, without emotion. Those are great skills to have. Now, our final step on this slide is a CRES certified radiology equipment specialist professional, okay? The CRES tag at the end of your name just validates that you have imaging knowledge. I know it says experience. To me, it validates that you have the imaging modality knowledge. It's professionally recognized, and it can and typically will help you on your career path. All right, so if you're an imaging service engineer, I'm going to pick on one of the people in the crowd here, Roger Crisologo. Happens to work for me. He's been an imaging service engineer for a long time. He's probably the best imaging service engineer I've ever met in my entire life. And I don't say that to blow smoke, Roger. So Roger recently attained his CRES. Was it a year and a half ago, 2 years ago? Yeah, he actually inspired me to go out and get it, and for me to go out and set the example for other imaging service engineers that I lead. Roger now has additional career growth opportunities based on that certification, right? I think it's a great thing. Can we go to the next slide, please?
Yeah. I'm going to ask you one question, Roger, before we move on. I know Keith's got this slide too. Did it change the way you felt about your career? Did it change your, do you think it catapulted your career at all, or don't say anything negative about it? That's all I'm asking you. I mean, you could poo-poo it all you want, but I'm just stay positive. 0 to, huh?
We've got 14 minutes and 8 slides left.
Okay.
20 years ago, it made it easy to take the test. Plus, a lot of this stuff is more processors and stuff that was involved a long time ago. I think I don't know.
On the exam it did? It kind of helped you? Yeah, because you knew. No, we just, they haven't, I don't know if they've come up with a whole bank of new questions. They might have, but I know the breakdown for sure, because they did do a letter, item writing project about a year ago too. Another, a new questions into the bank, which is good. You don't want someone that's brand new to the field having an answer a question about a 20-year-old system. Or, yeah, good, yeah. Okay, like I said, we're gonna try to boogie through because we got a few minutes left, and I'm gonna make sure, Kate, this is up to you again.
All right, thanks. So we talked a little bit on the last slide about moving BMET skills to imaging service engineer skills. A lot of that is a mindset. It says mindset right at the top of the slide because that's what it is. When you're a biomed, and this was talked about earlier as well, when you're working on an infusion pump as a biomed, the urgency to repair that infusion pump might be pressure from your manager. Hey, there's a lot of other infusion pumps in line to get that done. Can you knock it out? I'm not making light of working on infusion pumps. I'm just saying that the urgency there is much less. The C-suite doesn't know about or care about that one infusion pump because they've got hundreds of others that they can substitute in for it. When you're working on a critical imaging modality, everyone is aware. And because everyone's aware, when people's bosses are aware of something, they tend to be more aware of it themselves and they want to vocalize about it more. So emotions run high surrounding imaging service events. You got to understand that. That's why on the previous slides I was talking about where it says volunteer to shadow, follow around and understand, bring that person making the transition with the senior imaging engineer to those events so that they can see that emotion run high, so that they can watch the modeled behavior of how to communicate with that staff, both in person and over email to let the C-suite know what's going on. Work hours are very, did I hear something? Sorry. Say it again. Yeah, but we don't want Bob to be the mentor. Work hours are very different. Anybody that's an imaging service engineer here work on either CT or MRI or both? CT, MR? How long does it take to perform calibrations after you swap out a CT tube? Typical, I don't care about manufacturer. Anywhere from, what did you say? 3.5's fast. Roger knows what he's doing, been doing it for 600 years. He's really quick. Sometimes it can take you a little bit longer than that, right? Sometimes it can take you 6, 8 hours after you got to run it through cals. It takes a long time. And you're not doing this Monday through Friday, 8 to 5, typically, right? They want that system back up now, yesterday. So your work hours are going to be different. There's going to be times as an imaging service engineer where there's not much going on during the day. And there's going to be times as an imaging service engineer where you are working Sunday at 2 o'clock in the morning to try and get that system up before patients arrive Monday morning. We've already talked about the type and complexity of repairs and the urgency. Interacting with the imaging leadership, like I said in the previous, emotions are going to run high. It's critical that your imaging service engineer understands that and doesn't take those high emotions personally, and more importantly, doesn't, I would say, doesn't stoop down to that level. If name calling starts happening, you don't want your imaging service engineer to be involved in partaking in that. They need to remain professional, cool, calm, collected, stick to the facts. Managing contracts is something that imaging service engineers may be involved in that oftentimes biomeds are less involved in. And the next thing here, value of specialization. When you become an imaging service engineer, you are kind of a master of all, but not so much. Not so much. This is that jack of all trades, master of none. So when you're biomed, I talked a little bit about this before. I said you work on things that are related to therapy, diagnostics, monitoring, treatment, all of these different things. I mean, literally thousands of different devices and modalities in the biomed community. In imaging, you've got a handful of modalities, maybe 7 or 8 modalities, right? Between anywhere from ultrasound to radiation oncology. And there is value to becoming specialized. If you are the go-to person for a specific modality or even a specific manufacturer's group of imaging devices, you're highly sought after and you will be paid well, commensurate with that expertise. So these are things that if you're chasing money, if that's what's important to you, it'll be highly valuable to you to become specialized on one or a couple modalities or one or two OEM product lines.
So this is how we talked about this, is a little slide about how to bridge the gap. Again, as we went over a lot of these in the initial part of the program, was identify those biomeds that have the skill set that you might want to try to foster to your imaging group. They should consider the time and workload that's going to require and how they're going to attend training if that's going to happen to them. I kind of recommend a little bit of identifying, put them through a little bit of on-the-job training as you're going along to identify to see if they're going to be the person, the candidate that's going to go for that expensive OEM, go to RSTI, take a class with me in the internal training and go through CBIT College with John and to see if we're going to put them through a biomed to imaging specialist kind of class. By the way, I just need to ask, do imaging techs get paid by the hour or are you guys all salary? Huh? You're hourly still? Geez. Okay, I didn't know that. I thought
We're gonna have to take a look at that.
yeah, I thought you guys were all salary. I didn't know, because I used to tell the biomeds, you know, you guys could be working on call all the damn time. you know, no kidding. So again, we're always trying to, okay, so we identify a good biomed, we know he could do it, we have some time carved out for him to learn it, and then we need to start planning out some structured training for them, right? Another thing we're working on too, Keith and I and our organization, is how to structure and document and track and plan OJT. OJT has been a big thing in the biomed world and in the imaging world too. A lot of times we get somebody and we have to train them on site how to do stuff, right? Even though I'm going to have someone work on 6,000 infusion pumps, they're probably not going to go to manufacture infusion pump training. We're going to train them on site and teach them how to do it and then send them on their way, right? So we're trying to develop that training path, OJT, and to formalize it somehow. Still in the process of it. If someone out here has got a really good in-house formalized OJT training program, send me an email. I'd love to talk to you about it. Tracking the progress is, like I said before, that's kind of a big deal too. We want to track the progress. You know, day to day, is it kind of, are we going to keep moving forward with this, or is it kind of stall out? Reassess the skill gaps as we kind of go along, right? As devices enter the facility. Biomeds more and more are seeing more imaging devices. I'm an old OR guy, so I kind of used to see imaging devices just kind of come through from C-arms and portables and things like that. Didn't get a whole lot of exposure to all the other stuff, but you know, we want to make sure that our biomeds and imaging team are working well together. And I'll tell you the truth, and this is the damn truth. As an in-house biomed for many years, even when I worked for GE or worked at Stanford, to try to interface with the imaging person when they came in was almost impossible. Even as an OR tech, I'd call my OEC guy and I would say, make sure you come see me when you pop in, because I want to see what you're going to do, right? It was almost like a mysterious like movement, you know? They would like bypass me into the OR. I'm like, I wanted to see what he was going to do, you know? Just so I could learn a little bit, right? So it was always kind of a interesting imaging, not wanting to interact with biomed being afraid to interact with imaging. So again, this pathway is it's fraught with some steps that we need to kind of work with and make it work. So here's Keith, I'll let you take this one.
Yep. So I'm going to summarize for time because we've only got about 4 minutes left. So there's a lot of opportunity for growth. There are more jobs for imaging service engineers out there than we have talent for. That's why we have this presentation to talk to the folks in the room about how to grow your own. Mm-hmm. It's a very desirable skill set. Your engineers will be motivated typically by one of a couple of reasons. One is a love for what they do and the challenge of moving into imaging. Another one that's we see quite a bit is, hey, I want to make more money. Next.
And again, I like to keep the conversation going. Any other things you think about career value for being an imaging tech? Okay. I don't think they'll come turn off the lights on us, Keith.
No, but they may have other classes.
Yeah, well, they do in half an hour for sure. Training investment. So how can the organization? This is for you, Keith. I'll let you keep going if you want to keep pushing us along.
Yeah, these are just tips for how to have a successful program. You need organizational support. So to recap what we talked about earlier, try and get your folks into training, whether it's internal and on-the-job training or whether it's external. If you have an in-house program, equipment owners, so the hospital themselves can typically send their biomeds to OEM training. If you are utilizing a independent service organization, you may struggle to get access to OEM training. There are certain OEMs that will give you access to their training and some that will not, regardless. One important factor to keep in mind is that you would typically need a letter of agency. It's a memorandum from the hospital or organization that says, we, the hospital, hereby give such and such company, the contracted service provider, authority to act on our behalf, both in service and matters of finance. You take that paper with you, give it to the OEM and say, I'm as good as the folks that work at the hospital and get their paycheck from the hospital. Some OEMs will recognize that, others will tell you to go kick rocks. I wanted to re-highlight the importance of a mentor, the right mentor. We don't want Bob to be the mentor, maybe technical mentor, but don't be like Bob. Knowing your BMET that is making this transition is important. I had a mentor once tell me you got spring pullers and you got spring pushers for a reason. You wouldn't use a spring puller to push a spring and vice versa. And that's because everybody has different qualities and traits and strengths and weaknesses, and knowing the people and knowing what those strengths and weaknesses are is crucial to developing the right kind of team. Right? Maybe somebody was hired for this kind of a job, but they're really good at something else. It's okay to know that and to make adjustments. And retention's a big deal. It costs a lot of time, money, and energy. Could take you 3 years to develop a BMET into an imaging service engineer that can function autonomously. Right. It's not a 2-week program where they went to RSTI phase 1 and now they're an imaging service engineer. It takes time to go through all of that. Because it's such a long and costly process to do that, you really want to hang on to those folks. So consider retention strategies that can help retention and support career goals. You got to put some focus to it or you're going to lose that person. Let's go to the next slide, please.
So building tomorrow's leaders, this is just a quick slide about if you're going to inspire the next generation to become leaders or become service engineers and senior service engineers, whatever it might be, right? You want to identify your possible leaders in your industry, in your organization. I think we were at a couple of leadership meetings yesterday and talking about identifying and even asking people if they want to be leaders. Do they want to come out in the field and be a leader? You're a leader. You've been in the leadership council. Keith's a leader. You were initially in the field. I was a working biomed for many years that got asked if I wanted to become a manager, a supervisor, and leader. And at first I kind of didn't want to do it because I didn't want to leave my 9-to-5 job, and I didn't see how managing people would be that much fun. But as I grew and matured, I actually did really appreciate it. But you want to identify those possible leaders and try to foster that. If you guys, I think a large portion of you guys are management or leadership in this room already. You got to start building the next generation of leaders, right? By mentoring and leading, that's what we talked about before. Encourage your managers to come to conferences like this. That way they can hear it from somebody else other than yourself or from me. You know, my team would love to hear stuff from other than me. Come and speak at these conferences. It wasn't all that hard to get this presentation accepted. You know, you put a NASA abstract, you throw some information behind it, before you know it, you're standing up here in front of 30 of your colleagues talking, right? A lot of people don't love doing it, but it's kind of fun to share your experience, right? We want to strengthen the HTM workforce, period, whether it be biomeds or imaging techs. We're all kind of in this big game together. We want to inspire it. The entry point for biomed has never been better, and I don't want to say easier because it's still not easy. But we got some 19, 20-year-old kids that are coming through our internal training program for phase 1. And I say phase 1, phase 2, phase 3. We do that. We teach that course in collaboration with CBEC College. John's back there. And maybe first name, huh? Zach Nelson, back from CBEC College. We do all of our training with the educational platform from CBEC College. So phase 1, phase 2, phase 3, a phase connect class. I mean, we're trying to educate and build, because we can't go out there and hire. There's just not enough hiring potential out there. And we have a lot of We have what, how many sites we have out there? 200 or 300 sites out there. We have some hiring deserts out there. We're having a hard time finding people to take these jobs, oddly enough, right? But if I or Keith knows somebody, but we know it'd be a great biomed, doesn't have biomed experience, but we know they'd be good, we could bring them in. You know, hire them as an entry-level biomed and train them. You know, that didn't used to be the way it was. And create, again, we want to create a culture with Renovo. I'm saying we both work for Renovo. We really work on our culture a lot. It's a big deal. It's almost the most important thing that we do is work on our culture and make sure our employees feel that they're cared for and that they really are there to do the best they can. Certification bodies, we talked about Amy, that we talked a lot about the CRES exam exact already. Imaging portals, we know that the RSTI, the imaging, the OEMs, the RSTIs, the CBET colleges that are actually doing this kind of great kind of training. If you can get to the OEM training, it's a tough one, and I'll be real honest. As a hiring manager and a manager for a big department with imaging, it was tough to send some of our technicians to OEM training, and I'll tell you why. Because sometimes we'd send somebody to a $15,000, $20,000 2-week exam course, and then a month later they'd leave. You know, and we still, to this day, do not have some kind of way to have them sign away that we're going to take that money from them if they leave. We could have a little contract all we want, but trying to enforce that contract has been almost impossible for all the different companies and hospitals I've worked for. Them, yeah, you could sign it off all you want, but to make them pay, you know, you talk maybe their vacation time when they leave or do whatever you might want to do, but it's impossible to say you owe us 20 grand if you leave. You know, they're at-will employees. Hire and fire them whenever we want, right?
I will say in response to what Don is talking about, I always support training and always have. So my background from the Army would say, I would have leaders in the Army that would say, we're not going to send these soldiers to training. We're going to send these civilian counterparts to the training. And I would always argue that the argument from leadership was, if we send a soldier to CT school, then that soldier is going to transition to a new unit in the next 2 to 3 years. We're going to lose that skill set. And I would say, well, then send the next soldier, right? We're improving the field through adding skills, regardless of who folks work for. A lot of imaging service engineers toggle between working for the OEM and then coming to work for an ISO and then going to work at a hospital and then going back to work for the OEM. So I say more training for everybody. It benefits our field and builds up our skills.
Lifts the whole industry up, right? And so you see the ISOs, that all parts that are different, a lot of different companies that are doing this great work. The self-study and development, we talked about the Amy's webinars and local HTM chapters, which are, you know, imaging people are of course, should be going to those too. We talked a lot about structured OJT. This is a big deal that we're working with right now, working through as we go. Our key takeaways: clear pathway, biomed to imaging to CRES. You know, we like that pathway a lot. Developing and requiring planned, structured support and some follow-up. And again, the organizations and the hospitals support to do this. Is there an appetite within your own organization and with your own hospital to actually do this? You know, you want to start building this, having this idea implanted before there's a need, right? Okay, so Keith, did you have anything you wanted to add at the last little bit?
No, we're open for questions and answers. I know we're over time, but we're available to answer some questions. Yes, sir. Yes, this will be made available by MD Publishing on their YouTube channel. So you'll be able to watch the slides progress with the audio voiced over, just as if you were in the classroom.